the question. Someone please STEM. Please read out the
A
question.
28-year-old man was caught into house fire and burned some portion of his body and was taken to A&E. On examination, he is tachycardic, hypotensive, SpO2 is deteriorating, and chest X-ray shows bilateral infiltrates.
Okay, that's great. So this is another very lengthy station. So at first come to the burn. So before going to the burn, you will have to have a very clear concept about the layer of the skin. So in a very simplified way, I am telling you at first, like this one is epidermis, this one is dermis, and this one is hypodermis, right? So all of you know there are 5 layers of the epidermis. I won't really want to share those things, but this one is epidermis. Then one is hypodermis. So hypodermis has 2 layers. So how many layers do hypodermis has? Hypodermis has 2 layers. One is papillary, and another one is reticular layer. And this one is dermis. I did a mistake. This is dermis. Exactly. Sorry. And this one is hypodermis. Hypodermis. Dr. Badon, are you here? Okay, this one is hypodermis. So
yes, bhai, I'm here. I'm having some network problems. That's why I couldn't participate that
okay,
much.
no problem, sister. Okay, just always remember, almost all the capillaries and the nerve endings are extended up to this portion, and that is the reticular layer. So how the burn are classified? There are 4 degrees of burn. At first degree burn, always epidermis will be affected. In the second degree burn, that is classified into 2 ways. One is superficial partial thickness burn, and superficial partial thickness burn comprises epidermis plus papillary layer of dermis. Did you get my point, doctor? Did you get my point? Then come to the deep. So second degree burn is divided into superficial partial thickness and deep partial thickness burn. So deep partial thickness burn comprises both epidermis plus dermis, right? Then come to the third degree burn. It is the full thickness of burn. Full thickness burn beyond the reticular layer. What is that? Beyond the reticular layer up to hypodermis. Dr. Nahida, are you here? And 4th degree burn. Dr. Nashid, are you here? Beyond hypodermis. Beyond hypodermis plus other structures. These are the classification of the burn. So burn is classified into 4 degrees mainly. Epidermis, 1st degree. 2nd degree burn is superficial partial thickness, deep partial thickness. 3rd degree burn, full thickness burn, and 4th degree burn beyond hypodermis, which involve other structures. So always remember, superficial burn is up to this portion is superficial burn. Superficial burn. And this portion is known as deep burn. Did you get my point? Now I will come to more details about the burn. Did you get my point, doctor?
Yes.
Okay.
Yes.
Okay. So now come to the another point.
Please tell me the deep partial thickness and full thickness burn.
Deep partial thickness burn is epidermis and all the layers of the dermis, 2 layers of the dermis.
Okay.
Papillary and reticular.
Okay, then full thickness.
Full thickness just beyond the epidermis that involves the hypodermis, this portion up to the hypodermis. Did you get my point? Bhaiya,
Okay. Okay.
okay,
Okay. Okay. I get the
who is
point.
this? Who is this Shubha Bhaiya? Right. Now
Okay.
we'll come to the superficial burn and deep burn right now. This is the demarcation. So this one is superficial and this one is deep burn. So at first, just it is the superficial, just this is the burn portion, and look, this is the other structures below here, this is the other structures below here, and this one is the blood vessels, this one is the blood vessels. So what really happened here, when there is any superficial burn, this is the blood vessels. So when there is any superficial burn, that will at first involve the keratinocytes, some keratinocytes here. What is the name of the cells?
Keratinocytes.
So that will damage the keratinocytes. So it is the keratinocytes. Keratinocytes. So when keratinocytes is damaged, it will recruit mast cells and macrophages here. So at the superficial burn, the keratinocyte is damaged and it will increase recruitment of the mast cell and macrophages. So this cell will produce some cytokines. Those are called pro-inflammatory cytokines. So what are the pro-inflammatory cytokines? Pro-inflammatory cytokines.
Tumor necrosis factor.
So pro-inflammatory cytokines are interleukin 1, 6, 8,
1,
tumor
6,
necrosis
8.
factor alpha. So
Alpha.
when pro-inflammatory cytokines are released from these cells, so the function of the pro-inflammatory cytokines of the blood vessels to increase the vascular permeability, right? Did you get my point, doctor? So what is the role of the pro-inflammatory cytokines of the blood vessel? That will increase the vascular permeability. So fluid will seep out into the interstitium. So that will causes some edema. So fluid shifting and edema formation. And the vessels will be dilated, right, Bhaiya? The vessels will dilate. So one thing is vasodilatation. So there might be hypotension. Patient will have some hypotension. Will have some hypotension, and patient will have some interstitial edema. Now to the another portion. So as the fluid seeps out into this portion, fluid comes this portion, that will produce some blister here. Dr. Kaushik Haladar, are you talking? Please. Okay. So as the fluid seeps come into this portion, and that will produce some blisters here, and sometimes the blister rupture. That's why the surface of the superficial burn is always moist surface. So what is the surface of the superficial burn? Moist surface. And there is a vasodilatation. So what about the vascularity here? There will be some blanching. Exactly, where there will be some blanching. So what is the blanching?
Blanching is giving pressure over skin will
Exactly. When pressure on the skin surface, blood will quickly fill up with increased blood flow to this area, because there is some vasodilatation. So there is some vasodilatation. So when there is some pressure of this portion, blood will when you relieve the pressure, blood will immediately come this portion, right? And as there is a vasodilatation, that's why the surface will be warm. So come to this portion again. As I already mentioned, that when there is some superficial burn, that will at first damage the keratinocytes, that will recruit mast cell and macrophages. This thing will release some pro-inflammatory cytokine, and this thing will cause vasodilatation. So vasodilatation causes shifting of the fluid from the interstitium, and that's why it was produce some edema, and fluids comes out, and that will produce some blister, and that's the sometimes blister rupture. That's why it causes moist area, and there is a vasodilation, the area will be warm, right? And there will be some edema formation. Did you get my point, Bhaiya? Alamin Bhaiya, did
Yes.
you get my point?
Yes.
Riyaz Bhaiya, did you get my point?
Yes.
Okay. Now come to the deep burn. So what about the deep burn? So always remember, deep burn, I have already mentioned that it's a very deep and it almost covers all the layers of just beyond this portion, epidermis and dermis and full thickness burn beyond the hypodermis. These things are the deep burn. So that will just cover everything of this layer. That will cover everything. So there will be vasodilatation here that will causes destruction of the reticular layer, right? Reticular layer, and there will be so
Nerve
much,
endings.
exactly, there will be so much inflammatory process here and vasodilatation here also, and that's why patient will have some hypotension. So now come to the reticular layer. So as there is some reticular layer injury, so will there be any sensation intact?
No.
No sensation.
No,
So
that
due to
nerve
nerve
endings are already
nerve
destroyed.
ending, exactly. So no sensation, right? Nerve ending injury, so no sensation. So what about the skin? Skin will be laxy, white or charred black, right? And leathery,
Because no blood vessels there.
exactly. And there will be some dryness here. No sensation, and no
No
blanching,
edema.
as there is charred the skin, and this is the
Superficial.
difference, the superficial and deep burn difference. Did you get my point, doctor? You will be asked about this portion, superficial burn, deep burn. I heard, though it is not given, but in our book this classification is given, but the conventional book doesn't contain this classification, and these things will be asked in your exam. So next you will be asked what are the classification of the burn. So what are the classification of the burn? Could you tell me what are the classification of the burn? One is rule of 9, right? One is rule of 9, and that is called Wallace rule of 9. And second one is land and Browder. So this thing is used only for the children, right? This thing is
Classification of burn or calculate the burn area.
Burn can be burn area, surface area can be classified.
Surface
It's
area,
not
basically burn.
classification. This is surface area.
We have
This is
already
not classification. It is
just discussed about the classification of this burn here, and this is the surface area of the burn, how it is calculated.
yes. How we calculate the surface area? Yes.
And the third number is Palmer method. So Palmer method, basically the palm and the fingers of the person represent the 1% of the burn, almost 0.8 to 1% of the burn. Like this one is head, neck, trunk, leg, and when you are keeping your hand like this way, so fingers are palm, so this portion comprises 1% of the burn, 0.8 to 1% of the burn. Did you get my point, doctor?
Dr.
Bhaiya,
Rifat,
please.
then number 2, Lard and Browder chart, we can measure both adult and children.
Adult and
Especially
children.
it is made for children because the children's head area is more than the adult,
decreased surface
and
area
the
of the burn
thigh area
surface of
is
the
less
head.
than the
Yes, Bhaiya.
yes. That's why it is made for both adult and children. Lard and Browder chart.
Exactly, Bhaiya. Absolutely. So, but it is the more prominently is used in case of children, right, Bhaiya? Okay.
Yes.
So now the examiner, how would you calculate, how would you manage the patient? Now come to the management of the patient. So at first I will manage the patient according to ATLS protocol. According to the ALS protocol at first. So the second management is, so ATLS protocol comprises airway. So what are the things we look for the airway, Bhaiya? What are the thing we look for air, especially inhalation injury, right? Inhalation injury. So there might be some hoarseness of the voice, hoarseness of voice. So in that case, there might be need of any intubation. So
laryngeal edema.
exactly. So second thing comes to breathing. So if there is a huge burn of the trachea and the pulmonary, please, someone please, if there is some noise, please mute yourself.
Some noise coming in.
Okay, right now. So second thing will come into the breathing. So there might be have some burn of the trachea and pulmonary burn. So this burn can impair the gas exchange. So this burn can impair gas exchange. So what will happen? So there might be some presence of full thickness burn of the chest, full thickness of burn of chest. So as the chest has been burned in full thickness, there will be loss of elasticity of the burn. So the lungs and other things can be inflated. The chest movement will be decreased. That's why our intervention is sclerotomy. Did you get my point,
That's
doctor?
why the difference between the CRISP and ATLS. In ATLS, we have to do some intervention like sclerotomy, but in CRISP protocol, we are not doing anything as a surgical procedure.
Yes, that's great to learn from you.
That's why the ATLS and the difference between ATLS and the CRISP.
Yes.
Am I correct?
Yes, definitely, Bhaiya. Definitely. I'm your lifetime student.
You are my teacher right now.
No, man, no. I'm just invited you to enrich our knowledge altogether. So we'll do some intervention. So in breathing, we'll do some intervention because there might be chance of full thickness of burn in the chest area. Then come to the circulation, and this is the most important. Circulation. So circulation is divided in so many ways. So could you tell me what are the ways circulation is divided? Basically, circulation is divided into some ways. Some are flame. In case of adult, there is some 2 ml per kg into percentage of total body surface area. In case of infant, that might be 3 ml per kg into percentage of surface area. And electric burn. So always remember, just don't make it complicated. Don't make it complicated like flame burn 2 ml per kg per percent of total body surface area, right? And in case of flame burn in infant, this one is the adult. Infant 3 ml per kg into total body surface area. And in case of electric burn 4 ml. Exactly, 4 ml into kg into percent of the total body surface area. So like you found, there is a flame burn of a 30 years old male flame burn, and you calculate the burn is 40% of this patient. What is the percentage? 40%. The examiner will give you a picture, and that you'll have to measure the surface of burn by Wallen's rule of 9, and the examiner will start to calculate, will ask you to calculate the total body surface area. So like this is 40% has been burned. Yes, who is this? Please mention your name. PC Dash, please continue, bro. Hello. I think there is some network issue. So the examiner will give you a picture, and he will ask you to calculate the surface of the burn. Like you have calculated the surface is 40% have been burned, and this is a flame burn that will also be mentioned, and patient is adult. So how much fluid you will have to give the patient? So what was the calculation? 2 ml, and patient is almost 70 kg. I mentioned that 30 years 70 kg. So what is the
40.
2 into 70 into 40.
40.
So what is this, bhaiya? What is this? What is the amount?
5,600.
5600. So
5.6 liter.
Within 24 hours.
exactly. So
Within
you will have
24
to
hours.
give 24 hours 5600 ml. So
In
then
3
you will
divided
have to
hours.
give the fluid by Parkland formula.
First 8 hour half.
What is the formula? Parkland formula.
Parkland
Parkland
Formula. Like you will have to divide this portion. You will have to divide this portion into 3 ways. 24 hours. First 12 hours.
50%.
50%. So what is the 50%, bhaiya? What is the 50%? Sorry,
Yeah.
8 hours. Sorry, first 8
8
hours.
hours.
20.
It will be divided into
8
3
hours.
8 hours.
50%.
8
What
hours,
is the
8 hours,
50%,
8 hours.
bhaiya?
50.
50%.
2800.
26. 2600 ml.
2800.
2800.
Exactly.
2800.
Exactly. So remaining
And next
24
8 hours.
2800 you'll have to give within 16 hours,
16 hours.
right? So this is the
Why
Parkland formula.
8 hours?
Because in the first 8 hours there will maximum amount of fluid loss, because there is so
Yeah.
many inflammatory.
First 8 hours, yes. Yeah, the vessel porous, the pore of the vessel will be
Porous,
more
leaky, and
Yes,
there will
more
be
leaky in the
leakage.
first 8 hours,
cytokine storm.
and it leak and the leak will completely stopped after 24 hours.
Yes, that will basically take via 3 to 4. The main storm is going on for the 3 to 4 hours, but within 24 hours it will be settled down, maximum condition. But maximum storm occurs in
Maximum
the
condition,
3 to
yes.
4 hours, right? 3 to 4 hours maximum burn
Yes.
shock occurs in the 3 to 4 hours, right? So this is a circulation. So at first I'm coming to the circulation. So this is we have divided into flame burn and elective burn. Flame burn is divided into adult and infant. In the adult 2 ml into per kg total body surface area, and infant 3 ml per kg total body surface area, and elective burn 4 ml. Right, we had divided took it into Parkland formula.
I have a
So,
question.
who is this? Fahim, please.
Him, I'm Dr. Yes. But we know that if there is more than 15% of burn, then we give the IV fluid. But is it only for the deep burn, or if it is only epidermal
Always
burn, but it is
remember,
more than
bhaiya,
40%?
always remember fluid is given, or these things is always done only for the deep burn. Only for the deep burn, not for the superficial burn.
Superficial don't need it.
No
Okay,
need.
that means in case of superficial partial thickness burn, in this case we don't also give the fluid, right?
Need. No needed. No needed.
But deep partial thickness, like
Yes.
where there is reticular dermis
It will
involved,
give.
in this case
Yes. What is the classification of this one? Is the superficial or deep one?
Is the deep one.
Exactly. So you'll have to
then deep
calculate this thing, right, bhaiya? Okay.
Okay, but I have another question, but I did not get this point that past 8 hours you were. Can you please clarify this thing?
Just look at
why
this
the
picture.
first-
Look at this picture. So we have mentioned that there will be so many inflammation, as there is some inflammation going on superficial burn also, but there is so systemic inflammation going this portion, and this is a vasodilatation, and there will be so fluid leakage from here to interstitium, and there will be some edema in this condition, and this portion body will lose some maximum amount of fluid, and the most inflammatory process going on at the first 4 hours, first 8 hours, sorry, 8 hours. That's why it is the maximum fluid resuscitation is given for the first 8 hours. Did you get my point, bhaiya?
Okay. But we know that that means choice of the fluid. Will you come after this or discuss here that
Yes.
first 24 hours we
Yes,
give only
yes.
crystalloid,
The
then after- but
choice.
indication, why don't give the crystalloid in
Okay, I am coming to
second
this
day?
portion.
Why do it?
I am coming to this portion. Basically, we'll choose here basically crystalloid. So this is the endotheliums, this is the basement membrane. So while we'll give the colloid, if we give the patient as we first 8 hours or the first 24 hours is the inflammatory waves and there is leakage of the fluid here, right? And the endothelium are very leaky with the first 24 hours. So if you give the patient any colloid substance has some colloidal osmotic pressure effect, right? Colloid exerts colloid osmotic pressure. So if you give the patient some colloid, as these things are very leaky, the colloids will come into this portion, and this is the interstitium.
Directly
Exactly.
in same concentration.
Exactly, this thing directly come to this portion. So as you are giving the colloid the patient, this will come into the interstitium, and this portion will have more colloid osmotic pressure, and the function of the colloid, so how colloid osmotic pressure is exact is just holds the water. So the this proteins or this
More
colloid,
edema.
exactly, the colloid will attract more fluid from this portion, and this thing will become more worse. That's why it is better to avoid the colloid within 24 hours, because the endothelium are more leaky. And if you give the colloid in this patient, that will come into the interstitium, and that will attract the water, and that will produce more edema. And this condition is called paradoxical augmentation of the third space or interstitial space. Did you get my point, Bhaiya?
Yes, Bhaiya, thank you.
Okay, that's great. So until so what endpoint of resuscitation until the normal output 0.5 to 1 ml per kg per hour it is reached. And along this side, along this treatment, we have already mentioned airway breathing circulation. Along this treatment, you'll have to also consider analgesic, you'll have to consider antibiotics, and
Nutrition.
also, exactly, anti-ulcerant. Those are things.
Anti-ulcerant.
You'll have to mention these things. Okay.
Sulfasalazine ওইগুলা sulfasalazine
Those things are,
medication.
I think those things are the superficial burn. Alan bhai, right?
Dr. Rifat, I have a confusion in my mind. If a superficial burn is more than 70% burn, superficial burn, so no need to use fluid.
I don't have any idea regarding this point, Bhaiya. Just I come to know because I read a large amount of information I gathered, but I always found that this fluid or these things are used only for the deep burn. There is nothing is mentioned regarding superficial burn.
This formula is for deep burn, yes,
Yes,
correct.
Bhaiya. Yes,
But
yes.
if there is more than 90% burn, superficial burn, no deep burn. So I think in my general knowledge, I think the fluid is needed.
Okay, that might be needed, but that thing is not for exam. Okay.
Okay.
No
Yes.
problem.
Yes.
That is for enriching our knowledge. Just if you have any idea, just enlightening us. But that thing is not needed for us for the exam. Thank you, Bhaiya. So the next question, the exam will ask you, how do you assess the adequacy of the fluid therapy? So you are giving the fluid. So how would you assess the patient? So clinically, you will have to take some clinical measures. So what are the clinical measures? So what are the cardiac index? Could you tell me, doctor?
Pulse, blood pressure, urine output,
And you can
and
also mention the peripheral warmth. Exactly, peripheral warmth.
capillary filling.
Exactly. So peripheral warmth, then pulse, then capillary refilling, blood pressure, and urine output. These are the clinical
Urine
measures you will look for at first. Then you can also, as you are giving the patient some fluid challenges, then you can also measure the central venous pressure. Then you
CVP.
can go for the core temperature, right? Rectal temperature, whether the
core
patient is having
temperature,
any
rectal
hypothermia or not. So,
hypothermia.
and ultimately there is some hematocrit. Could you tell me why is hematocrit?
Yes, there will be hematocrit increased as there will be hypovolemia.
So why?
So
Why
volume
this
correction will
happens?
get. If there will be volume
Due to
correction,
leakage.
then it will be
Exactly. Basically, like when
leakage.
like this one is if this is a test tube, and if you like this one is 100 ml test tube, 100 ml test tube. So you kept 100 ml of blood here, 100 ml of blood here. So you have done two things here. One is you added some anticoagulant. Second thing, you will centrifuge this. So when you are doing and giving some anticoagulant and centrifuge this, then you will come to know that there will be 3 layers. One is almost 45 layers, 45 ml, 45 ml. This is for RBC. One for this layer 1 ml. This is for Buffy code.
Another cells.
Buffy code, exactly. Other cells, WBC and platelet, and rest of the 54 or 55
plasma.
ml, these are called plasma. So this one is called hematocrit. So hematocrit is the percentage of RBC in total volume of blood. So what is the volume here? What is the volume here, Bhaiya? What is the volume here?
100 ml.
100 ml. And what is the percentage of RBC?
45 ml.
45 ml. So this is called hematocrit. So in case of burn, there is a leakage of this fluid.
Plasma loss.
So this is the plasma loss. These are the plasma loss. So if there is any plasma loss, the hematocrit or percentage would be raised. So it's a very important indicator. Hematocrit. If hematocrit is increased, that means the patient is having some plasma loss. It is also used in dengue fever. If there is an increase of hematocrit, that means patient is having plasma loss. Did you get my point, doctor? So someone tell me, how would you assess the adequacy of the fluid therapy? Someone tell me, how would you assess the fluid therapy?
The cardiac index.
Exactly. You are
Peripheral one.
exactly clinical measurement. Peripheral 1, then peripheral 1, then pulse, blood pressure, urine output. Then you are giving the fluid challenge and you are giving the patient some fluid, so central venous pressure, then core temperature and rectal temperature, exactly, then hematocrit. These are the things. So the examiner will ask you about the complications. So I have already mentioned that the burn have some burn shock, right? One of the most important, and within 3 to 4 hours burn shock. This is the burn shock. First complication, burn shock. So then there will be some ARDS. I will discuss about the ARDS very descriptive way. Then there will be some sepsis. Then there will be some acute renal injury due to breakdown of muscles, or there's a myoglobin urea, some electrolyte imbalance, hypernatremia, hyperkalemia, even hypocalcemia. So many electrolytes can be impaired. But these are the things we'll have to mention, at least 4 or 5 things. So one is burn shock, another one is ARDS, another one is sepsis, renal failure. These are the most important. There may be some compartment syndrome, and you will go for some scleroderma and so many things. But you have to mention at least these 4 or 5 things. Right? Did you get my point, doctor? Bhaiya, did you get my point? So
yes.
So how to differentiate between the superficial and deep burn? I have already mentioned these things. So we got one most important complication is ARDS. So
ARDS.
our next topic is ARDS, and this is another important chapter for today. So what is ARDS? ARD.
Adult respiratory distress syndrome.
Okay, so Dr. Russell said adult respiratory distress syndrome, acute respiratory distress syndrome. Na? So at first, A stands for acute hypoxemia. Acute hypoxemia. So usually duration is less than 7 days. Hypoxemia, history of the hypoxemia usually less than 7 days, and SpO2 usually less than 90%. Even okay, let it go. So R stands for ratio of partial pressure of oxygen and FiO2. Carrick index, we will discuss about these things later on, and this index will less than always 26.6. So then comes to the D is for diffuse bilateral lung infiltration. infiltration, and S stands for Swan-Ganz catheter to see pulmonary capillary waist pressure, and that is less than 18 mm of mercury. Did you get my point? So as the patient is pulmonary capillary waist pressure, so why it is used to see non cardiogenic pulmonary edema. So what are the characteristics of the ADH? So tell me someone, what are the characteristics of ADH? Characteristics of ADH, it is an inflammatory form of lung injury. Are you guys with me? Are you guys enjoying, or you are bored?
No. Okay, continue.
So
Acute hypoxemia.
So
Yes.
patient will have
Even
hypoxemia.
resuscitation,
Yes, that's why.
even with resuscitation,
Yes.
then partial pressure of oxygen less than 90%.
Exactly. Then
And the ratio of partial pressure of oxygen and the ratio of the oxygen in the environmental air less than
inspired air,
26.
right? Inspired air.
Inspired air, yes.
And these things
and
is
both
called
lung fields
Carrico index.
Carrico index.
Okay.
Yes.
Both lung
And
fields
both
are
lung fields diffuse infiltrates.
exactly diffuse bilateral lung infiltrations. And fourth one.
As fourth one, Swan-Ganz
catheter
pulmonary capillary
inserted.
waist pressure.
Exactly, to see the
Yes.
pulmonary capillary waist pressure, and that
is
is
less than 18 mm mercury. 18 mm mercury, because there is no involvement of cardiac function.
Exactly, there is no cardiac abnormalities. Exactly. So
This is the assistant for Swan-Ganz.
yes, Swan-Ganz catheter insertion. These are the mnemonics basically.
to
You
see
will
the
ask
pulmonary
you
capillary
will ask about the ARDS. So what are the characteristics? So the examiner will ask you.
This mnemonic is made by you.
No.
While I was preparing for the exam, I come to know that these things is very difficult, and I forget those things again and again. And I have made so many things. I have collected so many things from so many places. So
yes,
yes,
we are enjoying this.
So acute diffuse inflammatory form of lung injuries and characterized by ARDS. Those things have already been mentioned. So now come to the pathophysiology of the ARDS. Now pathophysiology. So always remember, ARDS is divided into two type of injuries. One is direct lung injury, and another one is indirect lung injury. So in case of direct lung injury, always there is a direct effect to the lung alveoli, like toxins, some burn, some pneumonia, some aspiration. These are the direct lung injuries. In indirect lung injuries, there might be sepsis. This comes through the blood. Sepsis. There might be some pancreatitis, transfusion related acute lung injury. These are the indirect lung injuries. So just have a look. These things directly involve the lung, but these things doesn't directly involve the lung. These are the secondaries. This comes to the bloodborne. So in this kind of patient, indirect lung injury, there will be you will get so many systemic inflammatory response, because these are the consequences of the inflammatory process. But these things are directly causes lung injury. So now come to the next point. Like this is lung alveoli. This is a lung alveoli, and this is the blood vessels, right? So there are two types of lung, two types of cells. One is type 1 pneumocite, And another one is bhaiya, another one is type 2 pneumocytes. So two types of pneumocytes are present in the lung. This one is type 1 and this one is type 2 pneumocytes. So what is the role of the type 1 pneumocyte? The role of the type 1 pneumocyte to gas exchange. Vivek bhai, are you there? Are you there? Guys, are you there? Please
Yes, sir. Yes.
just
Yes, I'm here.
try to participate here, not at a time, gradually, so that I can feel you are here with me, because I always worried with you guys, because whenever I write anything in your group, you don't like to give any reply. Just I'm after finishing this class, I don't want to finish all the relationships with you. I just want to stuck with you every single seconds, right? All you already know that I am not taking that much classes for the FCPS or residency or so many batches. I would like to give all my concentration to you guys. So just utilize me. If you don't, if you have any queries, don't hesitate to ask me, because I am all yours. So what is the role of the type 1?
Chala bhai, we will utilize you, especially me after Ramadan, definitely.
Okay, no problem.
Because in the Ramadan, I can give much more time in study.
Okay, bhaiya. So what is the role of the type 1 pneumocyte, bhaiya? This one is for gaseous exchange. And what is the role of the type 2 pneumocyte? To production of the
Release of
surfactant.
surfactant.
Forms of the surfactant. So when there is any direct injuries, like at first come to the direct injuries or indirect injuries, whatever the injuries is, there is a destruction of the type 1 pneumocyte, and there is this presence of, as it is inflammatory process, this is an injury, so there will be some inflammatory cells like macrophages, so other inflammatory cells. So what will happen? These cytokines will release or make the endothelius more leaky, and fluid will come from this portion to this portion, from blood to alveoli. So alveoli will full of fluid, and as the fluid is increased here, and this will won't able to produce any gas exchange, the first thing. So the function of the type 1 pneumocyte will be hampered, first thing. The second thing, as there is any type of direct injury, these cells will be injured, and these cells won't be able to produce any surfactant. So what will happen? If these cells can't produce any surfactant, what will happen, Bhaiya? Collapse.
The remaining portion, which might have the chance for gas exchange, already collapsed due to type 2 injury. Type 2.
Exactly. So there will be some collapse. So all of you can know there will be no gaseous exchange, and there will be some collapse of the lungs. So what is the role? Just have a look. The lung pulmonary vasculature, the pulmonary capillaries are vasculature depends on nitric oxide. The dilatation of the pulmonary capillary depends on nitric oxide, and this nitric oxide directly produced from the supplying capillaries of the endothelium. This endothelium produce the nitric oxides. Just have a look here. Oxygen comes to this way here, and oxygen comes here, and this endothelium produces nitric oxide by the help of the oxygen, right? How it is produced, just have a look. There is a protein here which is called arginine, and arginine synthesize nitric oxide by the help of the enzyme arginine synthase, and always there is a help of oxygen. So have a look here. No oxygen can come here. No, there is a collapse of the lungs, so no oxygen can come here. So endothelium will be deprived of oxygen. So they will be deprived of oxygen. So will any nitric oxide produced from the arginine?
No.
So their own production of the any arginine. So these vessels will be contracted. This vessel will constrict basically. That's why ultimately this event will eventually produce the pulmonary hypertension. Pulmonary hypertension due to low oxygen concentration. So what will happen if there is a pulmonary hypertension? What will happen? What is the role of the pulmonary hypertension? Like this is the heart. So this is the heart. So heart right ventricle can pass any blood to the lungs due to pulmonary hypertension. So ultimately right heart will be failed. Right heart will fail. So as right heart will be failed, so JBP will be JBP will be raised. There is some ascites, some hepatomegaly, and so many things. So come to the conclusion. This pathophysiology has two steps. One is acute phase. Acute phase. In case of acute phase, is a type of indirect lung injury. In case of acute phase, the endothelium are injured here. Fluid will come into the interstitium and ultimately comes to the alveolus. So no gaseous exchange can occur here, and here is as the fluid comes into the interstitium, that will recruit some inflammatory cells like neutrophils, some macrophages, and this thing will produce some cytokines, and cytokines will make these cells more leaky, and more fluid come into the alveolus, and ultimately no gaseous exchange can occur here, and the lung alveoli will be full of water, stiff, and there will be some ventilation perfusion alteration. Did you get my point, Bhaiya? I just discussed this thing as a whole. Right now I'm just telling you the main steps. One is acute phase and another one is later reparative phase. So second phase is known as, so what is the second phase? I just discussed about the acute phase here, all the things I have discussed here. So what is the second phase? Later,
when the lung is trying to repair itself.
Yes, when the normal way, by the normal protective way, lung is trying to repair itself because formation of the fibroproliferation. So lung might be organization of the lung. Of if there is no
is there any time of late reparation phase?
I didn't get any time
in up to
I didn't get anywhere the time duration. Did you get it, Bhaiya?
No. I have no knowledge about that.
I can get though I gone through so many books for this portion, but always they are written there when the acute inflammatory process is subsided, then the lung process or pathophysiology goes to the second phase, then that is the reparative phase.
In Barn, you told us, or we know that
Yes.
24 hours, the 24 hours,
I
the
think that
vessels
when
will be settled.
when the cytokine system settle down here, I think after 24 hours.
Yes, I think within 2 or 3 days maximum acute lung.
I
Because
think
all
it
the
will
process
be the same as the inflammatory process, I guess. Inflammation is like that, acute inflammation, chronic inflammation. It will follow the same, I guess. Because all the response in the body is
in general, any inflammation in our body settle down within 72 hours.
Acute and chronic. Yes. 72 hours acute, then chronic by skin inflammation, it will take up to like 3 to 30 after 1 month, generally up to 1 month পর্যন্ত হইতে পারে.
Okay, that's totally depends on the severity of the injury, right? If the injury is persisting for a long period of time, so the acute inflammatory process will go for a long period of time, right? So I think that depends on the injury and depends on the cytokines. So always remember that when acute inflammatory phase is subsided, then that will go to the later reparative phase, and the later reparative phase there will be some fibroproliferation at first, so that will try to organize the lung tissue again. If no resolution, then collagen will be deposited ultimately scarring of lung
Start.
tissue, scarring of the lung tissue, and this is the phases of the ARDS. Did you get my point? Are you guys with me?
Yes.
Okay.
Yes, sir.
Okay. We do have Dr. Manarat. Are you here, Bhaiya? Saidapu, are you here?
Yes, sir.
Yes, Bhaiya.
Dr. Kaushik Haladar, are you
Yes,
here?
Bhaiya.
Are you bored? We just still going for the second station, right? I don't
I
know.
think we will go up to Sehri.
I don't know what will happen.
No
But
problem, Bhaiya. Continue.
but I think if you go through this way, you don't have to give more and more emphasis to break this thing, right? But if I just read it out for you, you will have to have a great fight to acquire everything, to memorize everything. So Anava, are you here, Apo? Okay, so let's come to the management of this patient. So I have already told you what are the causes of the ARDS, as it is written here: direct injury, indirect injury, and I'll let you know so many things from your book. But come to the management of this patient, management of the patient. So this patient ARDS, so this patient will be treated as ATLS or CRISP protocol. Hello guys, will the patient is treated as the CRISP protocol or ARDS?
Yeah.
Bhaiya,
The question, please, question again.
will the patient will be managed by CRISP protocol or ARDS? Particularly for
ARDS protocol.
Okay, is the
CRISP protocol or ATLS?
is it is related to burn, then we can start with like ATLS.
Bhaiya, but it is a complication of the burn. It is not the initial. ATLS is the
Here we follow the
protocol.
secrets.
yes. ATLS is the immediate and direct injury, but it is the complication of the burn, right? It is the
Complication burning. Yes.
That's why we'll manage the patient
The
according to
more goes to CRISP.
yes, CRISP protocol.
Care of critically ill surgical patient protocol.
So I will manage the patient according to the CRISP protocol, care of critically ill surgical patient protocol. So at first I will admit the patient in ITU. As is, I will let you know some indication of ITU admission, and there is a organ failure. So organ failure patient are treated in the ITU. So I will treat the patient admit the patient in ITU. At first, ARDS patients are treated depending on mainly 4 factors. At first, respiratory is the main problem. So our main concern is respiratory failure support.
Ventilation support.
Exactly. So respiratory support is some type of ventilatory ways are added here. One is moderate positive end expiratory pressure. So Dr. Anesthetist, Dr. Russell, what is PEEP? What is positive end expiratory pressure? Moderate positive end expiratory pressure.
Yes, I have also need clarification. Sometimes I am in confusion.
So are you here? Are you here, Dr. Russell? Okay.
Yes.
So what is PEEP? Anesthetist, what is PEEP?
PEEP, better positive end expiratory.
I know the abbreviation.
Positive and expiratory pressure.
So okay, no
Actually,
problem.
I think it is the pressure that remain the alveoli. Something open
Dr.
even after the expiration of the
Exactly,
air.
Dr. Fahim. I am really pleased to know that. Like this is an alveoli. This is an alveoli, and at the end of the expiration, there will be some air that remains in the alveoli so that alveoli can't be completely collapsed in this portion
collapse.
at the end of the expiration. Did you get my point? Bhaiya, Alan Bhaiya, did you get my point? What is
Yes, yes.
at the
Normal the expiration, sometime some
air
portion
is remaining
collapse.
by this. That's why it is called
Remain.
positive. Some air is given at the end of expiration. At the end of expiration,
Yes.
some pressure is given in the alveoli, and that is 5 to 15 centimeter of
10
water.
centimeter.
So what is the role? Why it is given? For the prevention of the
To
Better gas
Collapse of the
exchange.
patency
Exactly.
of the alveolus.
Prevention of the alveolar collapse. Right. Second thing, patient is prone position. So what is the advantage of the prone position? Dr. Anchal, what is the
It's improve
advantage of the prone position?
oxygenation.
Lung
So-
is less collapsed during prone
Aeration.
position, and the lung gets more space in the chest wall.
Actually, basically the blood, when there is a lying position, supine position, more blood is accumulated in the blood,
Better
in the lung, right? So when the patient is
dependent part.
prone position, the lung will get more space to be inflated, right? So this is the importance. So the oxygenation will be increased up to 65% in this prone position. So one is PEEP, moderate PEEP, that will keep some air inside the alveolus, so it prevents the collapse of the alveolus. And second one is prone position. The third one is very important. The third one is very important. What is the metabolic abnormalities in this patient, ARDS? It is respiratory acidosis or alkalosis?
ARDS, oxygenation.
Acidosis.
Acidosis. Very good, Apo. So the third issue is high frequency.
Any inflammation, common thing is acidosis.
Exactly, Bhaiya. So high frequency oscillation. This step is called high frequency oscillation. So what is doing here? There's two things that is given. One is high rate of respiration.
Rate.
So when the respiratory rate is increased, the intubation or ventilator machine is set in such a way the respiratory rate is more than 18 or high respiratory rate. So when there is any hyperventilation, the patient will lose some carbon dioxide from the body. So as the patient is having respiratory acidosis, so carbon dioxide will lose from the body and the situation will be improved. Did you get my point? Bhaiya, did you get my point?
Yes, yes.
So one is high rate, so decrease carbon dioxide, and another one is low pressure, low tidal volume or low pressure. So low tidal volume, so lung won't be inflated as much as normally inflated. So low tidal volume will be given, and another one is high rate will be given. So there is a low lung injury,
Compensation as a whole.
lung injury. So alveolar injury will be decreased, and carbon dioxide will be washed out from the body. So this is the third one, and the fourth one is inverse ratio ventilation. So it is not that much important. It is a mode of the mechanical ventilation that uses an inverse inspiration and expiration ratio to improve the oxygenation and gaseous exchange. Just try to mention those things, you don't need to know in details. And fifth one, it is not also that much practical. Extra.
I have a question.
Here we have just wait for a while. Corporeal membrane oxygenation. It is the artificial lung. Now tell me, Bhaiya.
Bhaiya, you said that is the respiratory acidosis, but I know that actually ARDS is a type 1 respiratory failure, if I am not wrong. So in case of type 1, there is only hypoxia, there is no hypercapnia. So as there is no hypercapnia, so how the acidosis is being produced here?
So always remember the type 1 ultimately, if the condition is progressed for further, it ultimately causes the respiratory failure, and there is type 2 respiratory failure, and patient will have more carbon dioxide. When there is a type 1 and ultimately it progresses to type 2, always remember such a way. As the
Okay,
patient,
okay, now I get the point.
as I already mentioned, just look at the pathophysiology. As I mentioned, there is no gaseous exchange, so carbon dioxide will keep accumulating inside the body. Just remember those things, just nothing else. So carbon dioxide will keep accumulating in the body. So carbon dioxide will bind with the water and ultimately come to the carbonic acid, and carbonic acid dissociate the hydrogen ion and biochemistry. So as the hydrogen is increased, so it leads to respiratory acidosis. Did you get my point here?
Only pulmonary embolism, there is respiratory alkalosis.
Alkalosis, exactly.
Because of increased ventilation,
Okay,
pain.
so fourth one is extracorporeal membrane oxygenation, and this is the artificial respiration. And another thing you can mention that is inhalation. I'm extremely sorry, my worst handwriting. Inhalation of nitric oxide or prostaglandin I2. What is the role of the prostaglandin I2 or nitric oxide? These are for vasodilatation. So what will happen? Decrease pulmonary hypertension,
Gas exchange.
increase gas. Very good, gas exchange. So these are the respiratory support. Just now tell me someone, how will we give the respiratory support of the ARDS patient? Dr. Badhan, Apu, are you here? How will you just have a look here and keep telling me how would we give the patient respiratory support?
Positive respiratory support.
Exactly.
Patient should be in prone position and high frequency oscillation. Increase, what is the number?
Respiratory rate.
Inverse ratio.
Inverse ratio ventilation via inverse
ventilation. Extracorporeal membrane oxygenation.
Inhalation of nitric
and
oxide.
Inhalation of nitric oxide and prostaglandin I2.
Exactly. Now come to the
Bhaiya.
Second. Who is
Hello.
this?
Bhaiya, Dr. Vivek.
Bhaiya, please.
Can you please repeat the high frequency oscillation again? I have somehow missed it.
So in case of high frequency oscillation, there is two things. High frequency oscillation, we are doing two things. One is increase respiratory rate, then normal. Another one is low tidal volume. So what is tidal volume? The amount of air that is normally inflated, right? We take usually for a single breathing inspiration, right? So in case of respiratory rate, when there is a more respiratory rate, that will lead to, in a normal patient, when a patient is keep taking respiration again and again, that ultimately leads to respiratory alkalosis. So as the patient is having respiratory acidosis, so we are doing respiratory alkalosis by increase the respiratory rate. So respiratory, when there is a respiratory rate increase, lung will decrease carbon dioxide from the body. Second thing is low tidal volume. Normally a patient take 500 ml of air normally for inspiration, but if there is a low tidal volume, the ventilator machine is kept such a way the tidal volume is decreased, like this is 300, so alveoli won't be overinflated, so there will be low lung injury because this is the inflamed alveolus. So when there is a low tidal volume, there will be less lung injury or less alveolar injury. Did you get my point, Bhaiya? Okay, we have so many things to discuss.
Please explain extracorporeal membrane oxygenation.
Extracorporeal membrane oxygenation. Just have you? You are in the Facebook. I know you, and you heard a news few days back. A almost 17 years old male died a few days back, who has an artificial lung, right? And that is nothing but extracorporeal membrane oxygenation, the artificial lung.
Okay.
This membrane is produced like alveoli.
I don't know. Okay, then come to the, so our first support was respiratory support. Then our second support is pharmacological support. Pharmacological support of ARDS. So what is the pharmacological support? One is low dose steroid. So what is the role of the steroid? What is the role of the steroid? That will
decrease the inflammation.
Exactly, inflammation. And as the sepsis.
And decrease edema.
exactly, as it is a sepsis, we will treat patient as a sepsis 6. Will you tell me what is sepsis 6? What are the components of sepsis 6?
We will give 3 and take 3.
Okay, okay, that's great. So now come to the
In answering of this question, when the sepsis comes, so only we will tell sepsis 6 or we will tell detail.
No, we just tell to the basically they will ask you the management. Basically, they won't ask you by this source. Say they will ask you how would you manage the hemodynamic, how would you manage the circulation of the ARDS patient, how would you manage the airway of the ARDS patient. They won't ask you the whole thing at a time. So they just may ask you what is the role of the steroid in the pharmacology, but just only by this way. But they won't ask you just tell me the management of the ARDS patient. But in case of, if they ask you management of the ARDS patient, just tell about the headings of this patient: respiratory support, pharmacological support, hemodynamic support, nothing else.
Principle of
principle of the management, right? So in the hemodynamic management, at first I will give the IV fluid, and always remember I will give the IV fluid, and always keep on focus. So Dr. Nahida is Dr. Nahida's voice, right? মা ডাকছে. Okay.
Yes, sorry.
No problem.
বাচ্চাকে বাবার কাছে দিচ্ছে, নাহলে আপু ক্লাস করবে কেমনে?
This is the right of doctor.
So at first I will give IV fluid of the patient, and always keep mind so that patient become fluid overload. Keep on mind, so patient don't become fluid overload. So we'll give the IV fluid, then we'll assess the patient vitals, right? What are the cardiac index? The cardiac index will assess, like blood pressure, pulse, urine output, will assess. So we can also use the Swan gas catheter to monitor the pulmonary capillary waist pressure, to see the, if no improvement, so we are giving the fluid and still there is no improvement, circular improvement, despite adequate hydration, then we can use dopamine in a low dose. I will discuss about all the things in the steroids later on. Low dose. In the low dose, dopamine has vasodilator effect. Basically renal,
especially for
renal vasodilatation, right? And we can also use dobutamine. What is the role of the dobutamine? Dr. Fahim, what is the role of the
heart rate?
Is a positive inotropic force of contraction, basically here, not the heart rate, force of contraction.
Okay.
And if there is if fluid overload, what is our load? Dr. Annaba, what is our load? What will we give the patient? Furosemide, and always 40 to 120 ml per 24 hours. So
in our assessment, in any moment when we find the fluid overload, then we use furosemide.
Exactly, Bhai.
Exactly. Is it true?
Exactly, Bhai. We already mentioned.
Not always we use furosemide.
Yes, when there is any fluid overload, if fluid overload we have mentioned, so this comes here. So if there is any fluid overload, we will give patient furosemide. Dr. Shobha, did you get my point? So now to the
yes, I get you.
other supports. Where is your colleague? Is she in the class?
No, in Ramadan he is not in class.
Okay, so other supports, one is nutrition. What are the things we will give the nutrition after, basically after 48 to 72 hours of mechanical ventilation, will have concern about the nutrition of ventilation. So what are the things we'll give for the nutrition of the after removal of the ventilation of the patient? Always try to avoid which kind of food we will try to avoid? Dr. Fahim, which kind of food we will try to avoid? Avoid carbohydrate. Carbohydrate. Why carbohydrate? Because carbohydrate metabolize and it forms carbon dioxide more and more. So if you take more carbon dioxide, more carbohydrate, then more carbon dioxide will produce in your body. So try to avoid carbohydrate or take less carbohydrate, right? This is the first thing. Second thing, you can use some fat formula that containing anti-inflammatory vasodilators, and these are omega-3, omega-6 fatty acid, eicosanoids, linoleic acid, these things are just to remember. No, you won't be asked in your exam as much as the airway breathing or circulation will be asked in your exam. Just to remember what are the things we'll have to avoid in the nutrition and what are the things we'll have to take for the nutrition. So these are the supports, or these are the management of the ARDS. So these are the management. Did you get my point, Doctor?
When the patient is in the ventilator during this period, past 48 hours or 70 hours, will we give the IV fluid as 5% DNA?
No. This thing
Or
basically.
will give the nasogastric feeding?
I didn't get you. What did you say?
Actually, you mentioned that the nutrition after the ventilation, that means after 48 to 72 hours, when the patient is out of the ventilator, right? Then we'll avoid the carbohydrate diet. But I am asking you that when the patient is on the ventilator, during this period, will we give the patient the support through the IV intravenously or nasogastric?
Okay. Basically, in a ventilator patient, as soon as you insert the patient in the ventilation, you don't need to give any parenteral nutrition. Exactly. Initially, you don't need to give the patient any parenteral nutrition or TPN initially, because there is some indicators when after 5 days some weight loss. So many things we'll have to consider whether you are giving the patient any parenteral nutrition or not. That thing will come into the nutrition chapter. But always
like a post-operative patient, 72 hours.
Exactly.
We can maintain this patient with only fluid.
Only by the fluid. So always try to mention that we'll give the patient parenteral nutrition if the patient accept all the requirement for the parenteral nutrition, like weight loss, even after 5 days. These things I will discuss all these things later on. But if the patient is kept for the long period of time with the ventilation, definitely TPN, total parenteral nutrition, will be given the patient. Did you get my point, Bhaiya? Because patient have ventilator tube through the mouth and so many things, so always they always prefer the total parenteral nutrition. Did you get my point, Bhaiya?
Yes, thank you.
Yes, can you repeat hemodynamic monitoring?
Hemodynamic monitoring, you just repeat for me. Just look at the picture and you just repeat for me what are the thing. So
okay, we'll charge fluid and go. We'll then check for BP and urine output if adequate. Then
and
good.
we'll insert swan gas catheter, capillary waist pressure.
Swan gas catheter to
No
pulmonary
improvement.
capillary pressure.
We can use
no
low dose steroid for renal vasodilators.
Dopamine.
We can use dopamine for
and
positive
dobutamine.
anatomic function. If fluid overload here, then we consider fusamide. Okay, this and ultimately our last question is what are the long-term sequelae of the ARDS? So there is ARDS. I told you at last there is some fibrosis or scarring. So impairment of the gas section definitely. So decrease the lung compliance. What is the lung compliance, Dr. Fahim? What is the lung compliance? Volume change?
Ability of the lungs to expand.
Actually, the extent that to which the lung can expand.
not only the expandation, there's also some volume pressure change. You'll have to bring some pressure. So it is the ratio of the volume change divided by pressure change. So if there is a increase of the pressure, the volume how much is inflated or distended. So when elasticity is increased, the lung compressor will be decreased. Always remember, right? So you don't need to go through this thing. Just remember the decreased lung compliance. And I have already mentioned that there is some pulmonary hypertension, lung compliance decrease, and impaired gas exchange. These are the things. This is the long-term sequelae. So now come to the book. So calculate the surface area of the burn. We have already mentioned this. How would you manage the patient? We have done these things. Circulation, everything we have discussed. Why not to give? Just answer immediately. Why not to give colloid in the burn patient? Just tell me why.
Because
Doctor.
it has no
More
advantage.
capillary permeability.
It's
All the
costly.
candidates at a time, please. I don't need to listen from a single person. I just want to listen from everyone at a time. Just tell me why colloid is not given.
The capillary permeability is increased, so the
Exactly.
colloid promotes the colloid osmotic pressure makes the colloid go through the capillary into the interstitium
Exactly.
around, and that increases the edema.
Exactly. Then how would
So
we
it is a
assess the adequacy of the fluid therapy? How would we adequacy of the fluid therapy?
Initially, we start
Exactly.
with
We
the
have
cardiac
mentioned
index.
everything. What are the indications of the referral to a burn patient? This is important. When we'll refer a burn patient, burn shock, resuscitation, danger area,
Necessitations,
hand,
yes.
face, genital
genitalia.
involvement, then
And all type of electric burn also.
Exactly, chemical burn, significant edema. This patient will refer the patient to the burn department. What are the indications of the intubation of the burn patient? Just have to remember those things. Just have a look. These things are from the scenario. What are the things you'll have to consider for intubation of the patient? Or what are you afraid of complication of the burn? These are the complications.
It's a complete burn shock, ARDS, renal failure, constriction.
Exactly.
So
So how to tell if
Whole
there is
thickness
superficial
burn.
burn or deep burn? I have mentioned everything very in details. Classification of the burn, I have discussed all those things.
And differences.
So look at the X-ray. What are the differentials? What is the differentials? Look at the X-ray. Diffuse, pulmonary, lung,
Pulmonary edema, diffuse pulmonary
ARDS,
infiltrates,
pulmonary edema, and
pneumonia.
ARDS,
so what are the
and extensive pneumonia?
Exactly, Bhaiya. So what is the ARDS? What was the pneumonics, Bhaiya? ARDS. What was the pneumonia?
Hypothesis less
Acute
than 7 days.
hypoxemia. Acute hypoxemia less than 7 days.
Less than 7 days.
And
Less
ratio?
than 90.
Pressure oxygen.
Ratio will be
and
less than
Ratio less than
26 kilopascal.
Exactly. D for diffuse. Diffuse.
Bilateral lung.
bilateral diffuse infiltrates on both lungs.
S for Swan gas catheter.
Swan gas catheter to measure pulmonary waste
pressure.
Okay, that's great. Now come to the Carrico index. So Carrico index means is the ratio between the pulmonary arterial partial pressure of oxygen in the blood and FiO2 means means what is mean? FiO2 mean
Fraction of
inspired. Like this is
like 21%.
environment. This is your blood. So this thing will measure from the blood and this thing will measure from the environment or lung alveoli, inspired alveoli. So they will make a ratio between this thing, how much air has come into the alveoli and how much oxygen come to the blood. So if there is any abnormality in this portion, so oxygen won't able to come in the blood, right? And this is the nothing but Carrico index. Did you get my point?
Normally it is more. Normally the ratio is more than 400.
Exactly.
If there is any obstruction, so no oxygen comes to the blood, so ratio is quickly dropped.
Exactly. Dr. Annavar, did you get my point? Apu, are you here? She's not here. Dr. Badhan, are you here, Apu? Did you get my point?
Yes, Bhai, I'm here.
You don't have any question?
Bhaiya, today I have network problem and there are so
Okay,
many
no
people
problem.
talking at a time. Bhaiya, so many people are talking, so it's getting quite difficult to concentrate.
Okay,
Bhaiya,
okay, no problem, Apu. Just I just wanted to assure you whether you are with me or not. No problem. So, what are the pathophysiology of the ARDS? I have already mentioned that one an acute phase and another one later
Acute
reparative
phase, the
phase.
lung will be stiff, and reparative phase, lung will be lung has
Fibrosis
Resolution.
carrying fiber proliferation.
Okay, that's good. Okay, that's good. And you can go through this picture. And these are the causes of the ARDS. Just don't try to memorize every single thing. Don't need, not needed. You will just if you
that's
ask
clinically which is important. Just we have to memorize
exactly,
sepsis, gastric aspiration, head injuries, burn. Just daily clinical patient.
exactly, Bhaiya. Exactly. These are the highlighted. So just try to focus on those things, especially just try to sepsis and the infections. Try to remember these things also. So all the red marked portions and the infections. So what is the Berlin criteria? That's the FiO2, percent oxygen, and that thing we have mentioned here. The ratio normally more than 400, right? There more than 400 normally, but when it
Yes.
becomes 200 to 300, the mortality is 27%. When it becomes 100 to 200, 32%. When it's severe, less than 100, and mortality is 45%. Just have a look here, not that much important. So
And in case of ARDS, it will go to less than 26.
to 6.6. So what is the
Yes.
management
So
of
mortality.
exactly, Bhaiya? So what is the ARDS management?
CRISP protocol.
Patient is
Care of critically ill
where the
surgical
patient will be
protocol.
treated. Where the
ICU.
patient will be treated in the ITU.
In ITU, CRISP.
And we have exactly, and we have managed the patient in on what are the aspect. One is respiratory support. We have
Respiratory
managed
support,
everything.
pharmacological support,
These two are
hemodynamic support,
pharmacology and is the
and
hemodynamics
others.
and others nutrition support. I have mentioned what are the food we would like to avoid in this patient. What are the food, Bhaiya?
About carbohydrate
Containing food, and we will add fat.
Exactly.
fat,
Omega
more
3,
fat
omega
containing
6,
omega 3,
Like
linoleic acid,
eicosanoids.
eicosanoids. Very good, Bhaiya.
eicosanoids.
So long term sequelae, one is refractory hypoxia. What is refractory hypoxia? You are giving the oxygen, but
The
patient is not
hypoxia
improving.
cannot be corrected after giving oxygen.
Exactly. The lung complaints will be decreased and pulmonary hypertension. That's end for this station. Okay.